Okay, so the last bowel disorder that we're going to be going over is appendicitis. This is the inflammation of the appendix. The appendix is a little, this looks like a tail dangling off of the small intestine. We used to think it had no purpose, but now we know that it kind of acts as a reservoir for normal flora, so, it helps to repopulate your bowel with that good bacteria. Certainly you can live without it, though. So appendicitis is when that becomes blocked and inflamed and can burst. So this occurs more commonly in males than females, and it's typically seen more often in the pediatric population. It's one of the most common reasons for pediatric population to come to the emergency room. It can happen in adulthood too. It's more complicated and usually more fatal when it happens to an adult. So like I said, this happens when the appendix becomes blocked. That can lead to inflammation and even abscess. It can rupture, which is then going to cause major infection. So this used to be a death sentence, back in the olden days, but now this is fairly easily treated. So it's not as complicated as it used to be. So these are our risk factors, as being male and being, 10 to 19 years old. Not a lot of risk factors. This can happen to anyone, of course. So some clinical manifestations. This is pretty easy to spot, and when these people come in the emergency room, you also can tell right away that this is going to be appendicitis. So the pain starts out as kind of like a diffuse, widespread abdominal pain, and then it localizes to the right lower quadrant in what we call McBurney's point. So that's a pretty classic presentation of appendicitis. There will also be some loss of appetite, some nausea and vomiting, and then this rebound tenderness. So that's when you press on that right lower quad, may not be as painful, but when you let go, that's when it becomes unbearably painful. And this pain is very intense. Don't be surprised if you see these patients coming in the fetal position. They can't even straighten themselves out because the pain is so intense. There's also another sign you can do called Rosving's sign, is when you press on the left lower quad, they have pain in the right side. So our diagnostic test, of course, that classic clinical presentation where we can almost tell right away, oh, this is going to be appendicitis. But then we can also do an ultrasound or a CAT scan. Either one of those will usually tell us if this is appendicitis. In our area, we're usually doing a CAT scan more often just because for most of our hospitals locally, CAT scan's always on site. Where ultrasound may not be there for these smaller, more rural hospitals, we have to call somebody in for that. There's just a lot less ultrasound technicians than there used to be. We'll also look at the white count. The white count will be high, and you may see something called a left shift, meaning there's a lot of immature white blood cells, because this is something that happened pretty suddenly. This isn't an infection that was brewing for weeks and months. This happened within a couple days. So there wasn't a lot of time for that white count to build up to what it wanted to. So you'll see a big percentage of that white count as immature white blood cells. So the treatment is just one thing. We have to get the appendix out. We don't sit and wait to see if this is going to get better. This is an emergent surgery, so we're usually calling the OR team in the middle of the night if they come in. We don't want to sit and wait, because if we wait, then there's a chance for that appendix to burst. And we do manage the pain. This is extreme pain. They're going to need some serious pain medication, but we don't want to completely take the pain away because we need to know if that appendix bursts. So if you have somebody that has appendicitis and all of a sudden they're saying, oh, my pain's gone, I feel so much better now, I'm ready to go home, that's not a good sign, because that probably means that that appendix has ruptured, which initially, yes, that pressure is going to be gone, so they feel a lot better, but, then we have leakage of bowel content into the peritoneal cavity, so that's going to then lead to a really complicated infection that's going to be hard to treat. So our goal is to get that appendix out before it bursts and manage that pain. You're going to also need IV fluids because I said, sometimes they have vomiting along with this, and definitely a lot of antibiotics. So complications is that rupture, which is going to lead then to that bowel content leaking into the peritoneal cavity, which causes a peritonitis, and that can lead to sepsis. It's very hard to manage that. If that does happen, they're probably not going to be able to have a laparoscopic procedure, which is what we usually do for appendicitis. They may have to open this person up completely so they can wash that area out and clean out all of that, fecal matter in the peritoneal cavity, because your peritoneal cavity is usually sterile, so we do not want feces sitting in there. And if that happens, it can lead to a sepsis. So, like I said, this used to be a death sentence back in the olden days most of the time, but now, we usually can catch it before it ruptures. And even if it does rupture, they're usually pretty good about cleaning everything out and giving high doses of antibiotics to make sure that this sepsis does not occur. So, we'll talk about this a little more in class, do a case study or two, and if you have any questions, let me know. I'll see you there.